My name is Molly. I am a fourth year and I'm going to present today about foreign body aspiration. And I'd like to start by thanking Dr. Khan and Dr. Howe. So let's start with a case. We have a 3-month-old male who presents coughing and choking while eating mixed nuts. It's the chief complaint in triage. They're a junior resident who wants to ask, what's the next thing you want to know? You just see this pop up on the board. Yeah, they're breathing. Yeah, they are breathing. So ABCs, this child is sitting upright, they're breathing, they're moving air comfortably. They have breath signs bilaterally, they're well perfused, their skin is nice and warm, you don't have any cyanosis. What else do you want to know? They do not that we know of. That's a good question. Bilateral breath sounds. Yeah. So we'll go with vitals too as well. Afebrile, heart rate of 120. Difficult to count their respiratory rate because they're coughing pretty frequently, but they seem to be breathing comfortably. And their SpO2 is 100%. What is the next thing you want for this patient? What's the first step in diagnostic workup for this patient after you've examined him? Maybe a senior resident, perhaps. Oh, yeah, so Dr. Warshaw is saying rashes, look in the mouth. Yes, excellent. I'm saying after we've examined the patient, what's the next step for someone who has choking while eating nuts and is stable? Chest X-ray, excellent. Yeah, so for all of these stable, possibly aspiration risk patients, we are getting chest X-rays. We're also getting neck, chest, and potentially abdomen if you have concern for ingestion. But is there anyone who wants to take a look at this chest X-ray and tell me if they see anything remarkable about it? Someone said, Calvin said, the high hemidiaphragms aren't even. Yeah, excellent. So this patient is air trapping on the left side from foreign body aspiration on the left side. So this is one of the things that we're going to talk a little bit more about today and kind of what we can and cannot tell from our X-rays in this diagnostic workup. The agenda today is to talk a little bit about the epidemiology, the pathophys, the basics, the imaging, and the management. And then I'm going to talk about how the evidence is really not there for any of it. And at the end of the day, it's a lot about clinical gestalt, but this is how we're going to go through it. Our objectives are to recognize the signs and symptoms of foreign body aspiration, identify some signs on X-rays that are going to point towards foreign body aspiration, and then understanding the severe limitations of our history, our physical, and our imaging. The first for epidemiology, these are pretty common. This counts for about 17,000 ED, foreign body aspiration, it counts for about 17,000 ED visits a year in the United States. It's the third most common cause of unintentional injury mortality in children less than 1 year old in the United States, from the 2020 CDC data. More than 80% of the time is going to present in children less than 3 years old. And prior to the advent of bronchoscopy, this used to have a 25% mortality rate. It's very, very deadly. The things that patients aspirate commonly, for infants, it's typically more organic things, nuts, seeds, popcorn, food particles. It can also be hardware and little pieces of toys. And then for older children, as they're a little bit more mobile, they're getting into things like jewelry, coins, paper clips, pins, pen caps. Not uncommonly also, though, it's just things that weren't chewed up properly. So this is a piece of hot dog stuck in the trachea of a 2.5-year-old who arrived to an emergency department in cardiac arrest. This is a post-mortem image. So when do you suspect foreign body aspiration? So this can be really, really subtle. And so it kind of always has to be on your differential. So if you get that good story, they were choking, they have respiratory symptoms, great. It should be right in the front of your mind. This might be foreign body aspiration. But it can also present a lot more subtly. This can present something, recurrent pneumonia, recurrent wheezing, or, a little one that was diagnosed with asthma without any other signs of atopy or any family history. And they just keep coming back for these respiratory symptoms over and over. It can mean you should think about it anytime you have a respiratory diagnosis that isn't responding appropriately to treatment. So patients, again, things or having recurrent symptoms, wheeze that isn't responding to albuterol, recurrent pneumonias that aren't responding to antibiotics. And then I think you should just keep it in your differential with any respiratory complaint. If you just think about it, you're going to be a lot less likely to miss it. Can I ask for a junior volunteer, if you remember from med school, what the classic triad was for a foreign body aspiration? Or throw out any one of the three of the things. Decreased breath sounds, excellent, that's one of the things. No, but it's good. Well, I'm glad no one memorized it because it's not all that great. But it's cough, wheeze, and focal breath sounds. This is the thing that I was taught. This is the thing when you look in textbooks. This is this is typically how they present, what we expect. Does anyone want to take a guess of how frequently this actually presents? Sorry? Very rarely. I want to take a guess at a number. I heard 50. I'm going to go with that. It's between 40 and 50%. It's very, very rarely presenting as this. What you are although these three signs are fairly specific, it's somewhere between 96 and 98% specific for foreign body aspiration. It is very rarely the presentation and is incredibly insensitive for foreign body aspiration. They estimate somewhere between like 25 and 40% sensitive. What you are much more likely to see is a late-term sequela of, a long-term sequela of foreign body aspiration. So it very well may present as some sort of a pneumonia. About half of these are going to be, again, delayed presentation. And it may be the case that every time this child gets pneumonia, they improve. So, they have a foreign body, they do get some superimposed bacterial infection, they get antibiotics, they get better, and then they come back shortly after because the foreign body is still there causing irritation and asinitis or infection. The best thing to actually get in the history to kind of point you towards foreign body aspiration is a history of choking. This is present in about 80 to 90% of foreign body aspiration cases, when you look at the data retrospectively, when it is specifically asked about. That's not to say that it's, again, a sensitive marker for ruling it out, but it is something to ask about if there were episodes of choking earlier today, in the last few days, so on and so forth. So how to know if there is a foreign body? You're going to ask, do your history and physical. You could have an aspiration, you can also have an ingestion, and the signs and symptoms can be overlapping. So having these history of swallowing symptoms, dysphagia, refusal to eat, describing this like foreign body station in here, can be sometimes very different to differentiate from some other like pediatric GI complaints, gastroenteritis, gingivitis, pharyngitis, and your respiratory symptoms too. Having stridor, having cough, having wheeze, but either can present, kind of causing the other symptom because of how closely the two organ systems are in proximity. And they can also both present asymptomatically or after a long period of asymptomatic time. So you want to just keep this on your differential in the back of your mind always, that our little ones are putting things in their mouths and that it could end up in their respiratory tract or their GI tract. So let's talk a little bit about the pathophys of foreign body aspiration. We're going to talk about the anatomic determinants of where these objects get lodged. We're going to talk about the physical properties of the foreign body themselves and how they affect the tissue around them. We'll talk about the local tissue reaction to the foreign bodies and how different irritants are going to cause different local reactions that will present differently. And then thinking again about where in this patient's disease course you are seeing them and how it's going to look based on how long ago they actually aspirated. So we'll talk also kind of quickly about we're talking about the anatomy of the airway. I know we classically learn that most of our foreign body aspirations end up in the right lung because you have that nice, the right main stem bronchus is a little bit wider, it's a little bit steeper, and so that's where most of our foreign bodies are going to end up. About 85% of them are going to end up in the lung, but about 15% of them end up in the larynx or the trachea. The pediatric airway is like this conical shape. I know Dr. Chow was talking a little bit earlier about why we don't use cuffed ET tubes because we have this tapering shape. So if you look, the one on the right is an adult airway and the left is a pediatric airway. You taper down to the smallest point is at the level of the cricoid cartilage, somewhere around C6. And you won't always be able to tell that on an X-ray because there's not that mineralized cricoid cartilage yet that you can see, that you kind of see a little bit better in adults. But that's where you expect things to get lodged if they are going to get stuck in the upper airway. The things that typically get stuck in the upper airway are going to have more irregular shapes, and they're increased with a much higher morbidity and mortality compared with a lower foreign body aspiration. They're in a central airway. They are also more likely to be sharp or cause more local tissue damage. There are also several sites throughout the GI tract that foreign body ingestions can end up. About 80% are going to make it down past the esophagus, and they can get stuck at several different points, in the pylorus, the duodenum, the ileocecal valve, the rectum, or any sort of like congenital or acquired narrowing from stenosis or inborn errors. But about 20% of them will get stuck in the esophagus themselves. The point where you typically see these things most frequently lodge is at the cricopharyngeus muscle, this this horizontal constrictor that comes around the back of the esophagus and also attaches right on the cricoid cartilage. So the place that the level that you are most likely to get stuck at in the pharynx is also the most likely that you are to get stuck at in the esophagus. And this is a lot of the reason why you can get symptoms, one causing symptoms of the other. So if you have something stuck in the esophagus that's pressing and causing that local compression onto the upper airway, you would get airway symptoms in addition to having a foreign body in the digestive tract. Okay, this is what Dr. Silver also was talking about, a little bit earlier, and thinking about the anatomy and the shape. You touch the front of your trachea, you feel those nice firm cartilage rings. The back of the trachea is where there's a little bit more give. You don't have 360 degrees, of the cartilage wrapping around. You have that softer posterior wall. And then you have the esophagus right behind it that's getting compressed. If you are going to get something stuck in the, a coin-shaped object stuck in the trachea, it is more likely to be in this sort of sagittal plane. And so the way you'll see it on a chest X-ray is when you're looking at it, you'll see the long end of the coin, and from the side view, you'll see the whole coin. As opposed to the esophagus, which is going to get, for the most part, your like coin-shaped foreign bodies are going to get stuck in that horizontal view if you're looking from the front, and then they'll be in the long axis from the side. This is also not a perfect science. You will not see, the moment you try to look up any sort of information about this, the first things that pop up are articles about how this is not the gospel truth. It's just the classic teaching. Next, you want to think about the nature of the foreign body. So normally, when you're breathing in and out, you have nice inspiration and expiration. The airway is able, to stay patent, and you're able to oxygenate and ventilate easily. Some of our foreign bodies will only kind of minimally block the airway, and so that's why you might get that delayed presentation where you are not in any sort of respiratory distress. You can aerate and then you can oxygenate and ventilate right around the foreign body. What we see a little bit less commonly, but you do see sometimes, is complete airway obstruction. So in this, you can't oxygenate beyond it, and you can't ventilate out beyond, or you can't oxygenate past it or ventilate back up beyond it. So this will be something where you get atelectasis, you get compressive atelectasis, distal to wherever your complete obstruction is. And then the most common thing that we see is this like partial obstruction, or like a ball and valve is how they describe it. So it's when you take a deep breath in, the lung kind of opens, the bronchioles expand, you can get air past. And then as everything compresses and tightens back up, when you try to ventilate, you can't breathe back past the object. So you get air trapping, you get like an obstructive emphysematous sort of pattern. It's also important to think about the local tissue reaction that you're going to get from whatever the object is. Button battery is something we talk about quite a lot. They erode. They are like a true emergency, no matter really where they are. If they're above the diaphragm, that they need to come out very quickly because they'll cause necrosis. But something like peanuts, I don't think we think of them as being so deadly. They have, and peanuts or anything with oil, seeds, anything that have fats in them, cause a lot of tissue inflammation. And so even if you don't have injury immediately, missing them will lead to stenosis in the airway. And then of course, magnets, anytime there are two magnets or a magnet and another piece of metal, you worry about them getting stuck and pinching any surface that will cause necrosis between the two of them. As a quick revisit of the button battery, I know we like to bring this up a lot, but it's an important point to go through again of just identifying what a button battery looks like, because I don't think we use them very much in our day-to-day thinking about what they look like, even though we do use them in a lot of our devices. But they're this kind of like dual disc shape. If you look at it from the front, they describe like a halo, but it's this, right up over here. And so when they are lodged in the airway or the GI tract, this is what you will see, as opposed to a coin that's going to look nice and perfectly cylindrical. Although I did come across a picture, and I apologize, I don't have it right now, of two coins that got swallowed together and looked very similar to a button battery. But you have to really look at it hard and realize that it's not one smaller circle and one bigger circle, it's just two equally sized circles that are offset. But if there are two different coins, you might get something similar looking to a button battery. Yeah.
The common places that you'll find button batteries are children. They're in a lot of toys. And I know as a kid, I took apart every toy I ever had. So you have older kids that are taking apart their toys or breaking things, you're going to get loose button batteries. You also see them in hearing aids. So while us as young 30s don't use button batteries on a daily basis, unless we use an actual mechanical watch with a button battery, older people tend to use them and little toys tend to have them. So they are floating around more commonly.
Yeah.
I feel like the vast majority of toys our generation play with all have batteries. I think they're all over.
Yeah.
Right.
Yep. Okay. So then let's talk again about kind of the timeline of disease. So I think this is something that is a pitfall that we don't stop and think about when we're putting foreign body aspiration into our differential. So if you have this acute choking event, you have airway obstruction, it's a lot higher up in your thought process. Could be something that is lodged in the upper airway that's causing it. But after that period, the patient could be totally asymptomatic, or they could go to more subacute symptoms, cough, wheeze, tachypnea, or pneumonia, bronchitis type of picture. And then they can advance these late complications, abscess, pneumonia, hemoptysis, bronchiectasis. But it's important to remember kind of in this whole cycle that it can all move backwards. And so something that is, lower down in the respiratory tract can become dislodged and bring a patient back into an acute choking event, or it can move and go from completely asymptomatic to having these, these more indolent symptoms. And just be mindful when you're thinking about the respiratory pediatric patient that this is something somewhere in the disease course, that you could find. Let's talk about imaging. The first, as we talked earlier, for aspirated foreign body, the first thing you want is a one view plain film X-ray. You may, you'll probably get the neck and the abdomen too at the same time, but the chest X-ray is the most important, for looking at where most of your aspirated foreign bodies are going to be. And this again is only for stable patients. Anyone who is unstable anyway is not going for a chest X-ray first. So this is very rarely what we see. Only less than 20% of our aspirated foreign bodies are actually radio opaque. So it's not sensitive at all, this one view plain film for ruling out foreign body. Can anyone tell what this is, this foreign body? Huh? It's a tooth, yeah, this is a tooth that a child lost and swallowed down. Excellent. Sometimes you'll also see kind of some other things on chest X-ray that something is wrong, but you might not immediately think about foreign body. So this is a 3-year-old male who's looking out of breath. He ate ground nuts 2 days ago, and then the nuts were presumed to have moved from, into the main bronchus. This is where we see like a complete obstruction. So you get that post-obstructive atelectasis behind it. So it can look like this and white out of the entire lung. And these nuts were removed via bronchoscopy later in that day. The next kind of piece in your workup is do inspiratory and expiratory films to compare what the lungs look like after a deep breath in versus deep breath out. At the end of inspiration, for these partially obstructive, the ball and valve obstructions, you'll be able to fully open the lungs and get good oxygen in. But then as it kind of lodges in place, you will get this obstructive pattern. So you get hyperinflation of the affected lung and you get mediastinal shift away from it. So can you guys appreciate, can someone, is there a junior who can tell me what side the foreign body is on? The left x-ray is inspiration, the right x-ray is expiration. What side is the foreign body on? Yes, sorry, I'm a little short. Yes, it's the left. Great. Another alternative to doing inspiratory and expiratory films is doing lateral decubitus. You have to do bilateral lateral decubitus films. Normally when you take a deep breath out, the dependent side should collapse more. But if there is some sort of obstruction, it's going to collapse less. So we have this, the right and left lateral decubitus films. And you see hyperinflation on the left side during expiration compared to the right, suggesting there's a foreign body on the left. This is actually the same patient as the one previously. Another x-ray that you're going to look at is your neck x-rays. These can be really subtle and really hard to find foreign bodies if they're not radio opaque. When you have the patients do these x-rays, you want to make sure their neck is slightly extended so that you don't get like a thickening of the pharynx just from having the neck collapse down. But this is where you're going to be looking for some sort of like subglottic density or swelling, similar to what you would look for like a tracheitis. And just as an example of the pseudo thickening, so the one on the left has some subglottic narrowing, and the one on the right is just that the patient is tipped forward, and so all of that soft tissue is compressed down, but it's not actually collapsing the airway. Another modality that we can use is fluoroscopy, where you have the kid laying and do multiple x-rays in series, kind of quickly, not us, the radiologists will be doing this to see in real time which lung this has less excursion. CAT scan, pretty good test for seeing foreign bodies, just not the right test for what we want to do. They're nearly 100% sensitive at ruling out foreign body aspiration, but they come at the cost of ionizing radiation, and then they delay the course to therapeutic bronchoscopy. MRI, even better test, with again, just completely wrong indication. So they'll be even better at picking up like really subtle differences. Like if you have some sort of oily foreign body, like a nut or a seed, that'll show really subtle soft tissue density changes for the differentiate on MRI. But this typically will require sedation, and at that point, you've really just lost any benefit of doing this over going straight to the bronchoscopy. So let's go back to a different case and do a quick check to make sure I got my message through for the chest X-ray, for the importance of the chest X-ray. I'm going to ask for volunteers again. So this is a 2-year-old female. Chief complained of neck swelling for 2 hours, had a choking episode on seeds 6 hours ago. Maybe one of my senior residents, what do you see on the neck X-ray? I'm hearing some narrowing. I don't actually see narrowing on this X-ray. I apologize. This one's a little bit of a trick. There's something else that's staring at us on this X-ray. Yeah, this is sub-Q emphysema. This kid has been coughing for hours and has all of this sub-Q emphysema under the neck. So you don't quite know where your foreign body is from this one. So you go and get your one view plain film, and what do you see here? Rosie.
You don't see lung marks on the right side.
Yeah, right. You have increased translucency of the right lung, pointing to the likelihood that you have a foreign body on that side that's being trapped, that's trapping the expiration. But you're not convinced, so you want to do some lateral decubitus films. And you have your left lateral decubitus here and your right on the right. What do you guys see in these images? Yeah, excellent. So the left lung collapses really well when it's down. The right lung does not. So again, another thing that's pointing towards a right-sided foreign body. Excellent. This is really 90% of what I wanted to teach today. You did it. Great job. Then kind of the next step of all of this is that after all of your history, your physical, your x-rays, nearly everything is going to lead to bronchoscopy because it is the definitive diagnosis, it is the gold standard, and it is also the treatment. So there's, in every textbook you look at, they have all different versions of this algorithm that take you through, your pretest probability, your x-ray findings, and then what you're going to do based on that. But again, it nearly always ends in bronchoscopy. So let's kind of work through it. So, you have this history in physical, you start with an inspiratory and expiratory, your plain film and your inspiratory and expiratory chest x-ray. It can be normal, equivocal, or suggestive. If there's anything suggestive, you immediately are going to bronchoscopy. That is your next step. There's no reason to be, fussing around with other imaging in between. If it's equivocal, you maybe see a little bit of atelectasis, you maybe see a little bit of consolidation. This is where a little bit of your clinical gestalt is going to come in. You could just go ahead and treat the underlying cause, but if you're not really convinced there's something else, you're a little more on the fence, this is when you'd move to fluoroscopy. And then if there's a foreign body, to the bronchoscopy. And if it's normal, then you'd observe. And with the caveat we say observe, all these things are in the context of coming back and having the patient come back in or see their PCP in a few days to make sure they haven't worsened clinically. If the chest X-ray is completely normal, but you have anything in your history that you really are just not convinced, you still have to get the bronchoscopy. The X-ray is not sensitive enough to rule this out. Unless you're truly sure there's no signs and symptoms, you really believe that this is not foreign body aspiration, then at that point you can say, okay, follow up in a few days, make sure nothing bad is going on.
I was going to say, I could attest to this. We had a kid who was transferred to us who got the x-rays. They looked completely normal, but given the history, they were like problems both diagnostic and therapeutic. Hers ended up being negative, but even though we had like a perfectly normal AP, like decubitus, they were still like, you can't know until you bronch them.
Yeah.
So.
Yeah, Rosie is pointing out that you really just can't know until you bronch the child. And so again, there's like a million versions of this in some way that all kind of point towards clinical gestalt. So I simplified this chart. There's a possible history of aspiration. You say yes, and you find some objective data, they're going to bronchoscopy. If you say no, then you go, are you sure? And if the answer is no, they're going to bronchoscopy. And unless you're really sure that that's not what's going on, then you can defer bronchoscopy. But there's a lot of clinical gestalt that goes into this. This is not something that I would feel comfortable at this point. Very grateful to have PEM faculty and attendings who can help us pull the trigger if we do need to do these bronchoscopies, but you really just can't rule it out on the plain films. For management, it goes back to very basic, ED care, hemodynamically stable or unstable. For the stable patient, if you have something in the upper airway, you can try to do laryngoscopy, either direct or video, and then remove the body yourself with something like a McGill forceps or an alligator forceps. You can use nebulized saline to try to anesthetize and keep down the gag reflex. But likely these kids are going to need procedural sedation. When you're setting up for this, you want to make sure you have your forceps, you have a variety of forceps available, so that if you can't reach your foreign body with one of the forceps, you can use something else, again, like an alligator. And then you want to have suction ready, because some of these things you can just suction out once you look into the mouth and then get rid of it that way. For the procedural sedation, be mindful if you're going down the route of ketamine, that you'll increase salivation. So you should consider using atropine or glycopyrrolate as well. For anything in the lower airway, this gets formed out beyond us. This goes to the OR for rigid bronchoscopy, again, for diagnostic and therapeutic modalities. For the hemodynamically unstable patient, ABCs, PELs, you can, if you're beginning chest compressions, you're getting ready to intubate, you're going to get set up with all your regular equipment and grab forceps. See if you can try to remove the foreign body. If you see a foreign body that you can't remove, you can try to intubate past it, or if it's lower down in the bronchus, you can preferentially main stem the contralateral bronchus. And as Dr. Lucchese always says, load the boat. If your patient is starting to crash and has a foreign body, you want to be overhead paging. If it's trauma, ENT, anesthesia, whoever is your backup, because this has the potential of turning into a surgical airway really quickly. We'll talk a few minutes about, yeah, Dr. Chow.
Mostly obstructed upper the it's not our instinct, because we're in the hospital setting to like maneuver. That's really what that means.
Yeah.
Like, we want to look it down and like open the airway and but really at that point they're like really on the cusp, but they're not quite there. That we can actually just need to consider insert them. Probably want to actually
Yeah, Dr. Chow is bringing up a really good point that we forget about, like the the BLS side of PALS, of just doing things like Heimlich maneuver, back slaps, and like for the little ones, because that's probably what they need more than us, laying them down and putting them in a position that's comfortable for us as opposed to them. Yeah.
If you can see something popping up and they open their mouth, you can try getting it, but if you can't keep distress and struggling, you're going to be fighting that. So just be careful about it. Get too comfortable. We want to solve all the problems with the position.
Dr. Khan is also pointing out for the hemodynamically stable patient, unless you can see the foreign body, that you also should really have like ENT, anesthesia, someone else involved, and it's not just us fixing this in isolation in the ER. Yeah.
They're stable because that foreign body is giving some leeway for the patients to still be breathing. If you try to go into the gills, you can lodge it, and then that patient is no longer stable or not unstable, and you can be in a much harder situation. So those kids just want to just go call anesthesia, call ENT. Once you paralyze them, right? If you have to do something, the only other way would be a paralytic, and then you have to do a surgery. So,
I'm going to spend a few minutes talking about the evidence, and just with the caveat that there's not really good evidence for any of these practices. There's the evidence that I've found is also not good evidence to support to move away from these practices. I just kind of tried to find articles that were cited frequently in blog posts or some of our foam ED sort of stuff. So this is a 2007 retrospective review in pediatric emergency care that looked at children less than 4 years old with suspected foreign bodies who had decubitus X-rays and bronchoscopy. They found that decubitus X-rays were positive, suggesting foreign body aspiration in 27% of children with foreign body aspiration and 33% of children without foreign body aspiration, which suggested that the decubitus X-ray didn't actually help differentiate whether or not these patients had a foreign body aspiration. Similarly, in a 2012 retrospective comparative study in the Annals of Emergency Medicine, they looked at the addition of decubitus to just standard view X-rays and found that it increases the rate of false positives. For adding expiratory films to the standard one view, it increased sensitivity and it increased specificity, but adding decubitus films to the standard one view didn't increase sensitivity and decrease the specificity of your findings. This study I do really like. It's a 2020 retrospective comparative study in Journal of Pediatric Surgery that looked at 133 patients over 6 years and found that the CAT scan is nearly 100% sensitive for ruling out foreign body aspiration. I'm not advocating any sort of practice change or that this is what we are going towards. The gold standard is bronchoscopy. But this might be something that in the course of our career, we see more about as you can decrease the radiation exposure.
Yeah, I will say that, there's two things, there's knowing that it's the gold standard, like getting into to actually mark them, or surgery to mark them, they'll almost always. Strong story, they will often suggest getting.
Dr. Chow was bringing up that most of our surgical subspecialists will want you to get the CAT scan before, you know, they do the invasive bronch. You know, my takeaways for this lecture today are first to keep foreign body aspiration on your differential anytime you have a respiratory complaint, acute, subacute, chronic. Just think about it, you know, as a possibility. Ask specifically about a choking history because that's going to be the best indicator to tell you this is a foreign body aspiration. Take time to think about where the patient is in their disease course. Just because they're here with an pneumonia doesn't mean this didn't start as a foreign body aspiration. And if you have a high suspicion for foreign body aspiration, you can't rely on plain films to rule it out. Questions? Great.